Hello, welcome to the Geri Academy podcast with your host, geriatrician Dr. Sharafsaleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media. Hello, welcome to the Geri Academy podcast with your host, Dr. Sharafsaleh. Today, we are going to talk about some myths. We're going to bust some geriatric myths, demythify. And my guests today, Dr. Cannon, Dr. Wang, my wonderful geriatric fellows. Hi, guys.
Hello.
So, Dr. Cannon.
Yes.
Want to sing us a song?
If I must.
You must.
So this is Geri Academy. Putting the pieces together.
That's right. We're going to put some geriatric pieces together today. But before we start with the official myths, I have one myth that's really important, I think.
Okay.
All the time, I hear this, geriatricians or older doctors, they're not fun. That is not true. We are cool. We are mostly young women. I mean, women dominate the field. And not only that, we have like the best job satisfaction out of any other specialty. I mean, that's reality. That actually is a true fact. So, Dr. Cannon, tell us about the first myth.
So something I hear all the time is, geriatricians only treat dementia. So untrue. We do everything. So geriatricians are trained to look at the whole person. And the first time you come and see us, it's usually about a 90-minute visit because we look at your medicines. We look at how you walk. We look at what you can do at home. Is there something we can do to help? And then we basically just spend a lot of time getting to know you because this is our first time meeting you. We want to know you and everything you can do. Yes, we do specialize in memory issues. But if you look at our blog, you can see when to see a geriatrician and see if any of that fits you.
Right. And also, when we see patients for falls, we generally incorporate, a lot of other things. Check out the Geri Academy blog, Don't Let Falls Get You Down. When we look at medications, we're looking at multiple disease processes. Again, it is a comprehensive evaluation by a geriatrician, which memory is sometimes a part of that evaluation. Mm-hmm. So what's the second myth, Dr. Wang?
So myth number 2, if I see a geriatrician, I will lose my primary care provider. Again, this is not true. Geriatricians are generally a physician, either an MD or a DO, who has completed their training and obtained additional training in the field of geriatrics, and they could function like primary cares or as specialists. And like any other specialist, people continue seeing their own primary care doctor, and they see the geriatrician for all the issues they discussed earlier.
Yep. There are so few geriatricians. Mm-hmm. Actually, one geriatrician, if they work as a primary care doctor, can take care of about 700 older adults. By 2029, when the last of the baby boomers turn 65, we are going to need about 30,000 geriatricians to fill that gap. I just saw your face, Dr. Cannon. Mm-hmm. But in order to fill that gap, we will not have enough geriatricians. And so geriatricians really work well as consultants. And sometimes when they do primary care work, they do specialize and address the entire need. But other times as consultants, they support the healthcare system. And, I think that we're pretty cool.
I mean, we get to make up fun songs.
We get to make up fun songs, right?
And then get roped into singing them.
I feel like...
Even if you got kicked out of your church choir because you're so bad, like I did.
I feel like this blog is going to have hints of how cool we think geriatricians are. So, okay, myth number 3.
So myth number 3 is that geriatricians only take away medicines. Very untrue. The goal of any geriatrician is to reduce pill burden, so reduce the number of medicines that you're on. And I think I remember in a podcast that we talked about, every single medicine has a 10% chance of having an adverse effect. So how many older people do we see on 10 plus medicines or 10 plus supplements? Because those can have side effects too. So your geriatrician and you will work together to see if any of these medicines can be taken away, or if you're having side effects that could be like falling, confusion, dry mouth. And we want to decrease the risk of having bad outcomes. So yes, we like to take away medicines if you don't need them, but we let you keep them if you do truly need them. I mean, who wants to take 20 pills a day? If we can get that down to 10, certainly I'd be happier.
Right.
I don't want to.
Right, yeah.
We were just discussing when we get older, we might need potassium. So do we want the big potassium pill that's a horse pill or the nasty liquid? We have to think about that in the future. We each have our own thoughts on it.
Pick your poison.
I'd much rather choke on a pill.
Poison.
I don't do shots well, so.
Yep.
So we did write a blog post, and we have the podcast, but am I taking too much medicine?
Mm-hmm.
And that blog post really goes into detail about when some medications are less appropriate than others for older adults, what interactions they may have. And then I can't remember if we talked about this, but that medication cascade, when you take a medication and it causes nausea, and then all of a sudden you're taking a nausea because of the side effect of that medication, and then you're taking this nausea medication that's making you sleepy, and then you end up falling and breaking a hip, and then it's just badness.
It's just a bad circle.
Bad circle.
Keep in mind, every medicine has a side effect, no matter what you take, so you always got to be careful.
Yeah, so going into falls, Dr. Wang, what is myth number 4?
Myth number 4, I only fallen twice in the past 6 months. I don't need to see a geriatrician. Well, 2 falls in 6 months are too many falls. So no matter how small a fall, they could lead to severe injury or even death down the line. So your local geriatrician could really help you and work with you together to look into the causes of it before anything bad has to happen, or before, like we said, you fall into the cascade of taking too many medications from that. So please check out the blog on Geri Academy on falls. Don't let falls get you down.
Yes, and we also had a podcast with Jonathan Williams, one of our favorite physical therapists, on falls and what happens during a fall assessment. But falling is a big deal because falling can take away independence. And so even if someone falls one time, I think it's important to look at the root cause of that fall, because could that mean that there could be another fall? I'm not talking about a stumble over a toy that someone left on the floor. I'm talking about instability, and it's really important. Falls are terrifying for geriatricians. All right, Dr. Cannon, myth number 5.
All right, so myth number 5. My family member is 99 years old and still on the same medicine. I should just continue it forever, right? So wrong. So some of these medicines were started probably when your family member was 40 or 50. And then as our bodies age, and you can listen to the aging podcast and read the blog, how we metabolize medicine changes too. And then some of these medicines that we were worried about in our 40s and 50s probably aren't going to help you when you're 99 years old. So you hear about your diabetes. So the goal A1C everyone hears about is 6.5. But if a 99-year-old had an A1C of 6.5, they might be getting low blood sugar that could make them fall. And then you hear about these statins that help with your cholesterol and your heart disease. Well, typically, at 99, they probably already have heart disease, and it might be making their muscles hurt and make them feel weak. So taking them off of that when it doesn't really have a clear benefit, if that would make me feel better, if my muscles didn't hurt and I didn't feel weak, I think I would much more likely to take that medicine off.
And if you have a shorter life expectancy,
exactly.
Right, we can think about life expectancy in terms of months to years. So if I think that my older patient might have a life expectancy of 3 years or less, then yes, I'm probably going to be taking them off some of the medications that may not even benefit them for another 10 to 15 years after they start taking them. And the patient can feel so much better. Because I'm telling you, if I was older, I'd go for quality rather than living maybe another few months longer and suffering. All right, Dr. Wang, myth number 6.
All right, myth number 6. My family member has a severe dementia. Is it too late to see a geriatrician? Well, it's never too late to see a geriatrician. Dementia, once you have that diagnosis, doesn't stop at the patient level. It became a group issue. It became a team issue. It affects not only the patient, affects their family member, their kids, their grandchildren, their doctors, their geriatrician. Everyone needs to step in and be able to help out. And seeing a geriatrician will help the family understand how this disease progresses, how much help their loved one will need, and what is to be expected down the line. So a geriatrician could help preparing not only the family, not only the patient, but also the family for what comes next.
Yeah. Did you have something you want to say about that, Dr.
And there
Cannon?
was actually a study that came out that people who saw geriatricians and had the appropriate training and counseling kept their family members out of nursing homes longer and kept them at home, which, that's the goal of pretty much everyone is to stay at home as long as possible.
Yeah. When we come to, the moderate demented patient, we discuss what is our goal is no longer to, cure the disease, or sometimes even delay the progress is unrealistic. So when we come to that level, we need to think about what is our goal when we're taking care of those patients. How do we make them more comfortable, keeping their function level as much as possible, and if keeping them at home will give them that comfort, make them happy in the last stage of their life, then that's where we could come in and help.
And geriatricians also give resources like the Alzheimer's Association, elder care, people that can come into your home and help you so your family member can stay at home. Again, it's just a geriatrician has all these insights that some other people might not have because this is what we specialize in.
And for those people that are at their advanced age, where the family are in distraught, where they're at the end of the rope, and we could also help out by advising on a placement so their loved one will be taken care of, and the family will rest knowing their loved ones are in a safe place.
Or even how to speak to your loved one, right? We can explain to a family member, your loved one is processing information at this mental age. And because of that, this is how you need to approach them. And this is how you need to speak to them. And maybe some words are appropriate and some words are inappropriate. And those are the things that end up keeping that patient at home with their loved ones, because loved ones know, okay, I can enter the bubble that this patient lives in. And when I can't do it anymore, I step out and somebody else steps in and takes care of my loved one. And we talk about caregiver burden.
Yes.
So a lot on this topic, again, because it is something that we do a lot of, but it is never too late to see a geriatrician. And I think we're also particularly good with medication blends, taking patients off of some medications because they could be causing some behavioral disturbance, or even adding some and the combination of some that could help with some of the behavioral issues. Okay, so who's up? Myth number 7.
So the geriatrician only sees patients in the clinic. So false. We go everywhere. That's the cool part of geriatrics is you can be in the hospital one day, in the nursing home like we are one day. You can go to a group dementia house, which is one of my favorite places to go. But it's really important to have a geriatrician in the hospital because they can see the hip fracture patients that might get a medicine to help strengthen their bones, or something that there's a blog on delirium, which is my favorite topic in the hospital, because you can help the patient be less confused, help them hopefully get out of this brain fog, because delirium is pretty serious, especially in the ICU. It has an increased risk of death. So if we can intervene and hopefully help these patients get through it a little bit quicker, it's great. And we also do advanced care planning or goals of care in the hospital. So if you're worried about this patient isn't receiving enough care at home, like home health or palliative or hospice, we can intervene and help the hospitalist or the primary care doctor get the patient the help they need.
And transition of care.
Yes.
Right? So we'll see a patient in the hospital, someone who we know has a risk of coming back to the hospital frequently. And we establish that care. We look at the root causes, the underlying reason. Why is this patient coming back to the hospital? And what do? We make a house call and we follow them into the home to understand a little bit about what is going on, or we'll follow them into the geriatric clinic to see what's going on, right? And so I think it's awesome. And I just realized something, or maybe this thought came into my head. You know how you have people sneaking around and popping their
That's us.
That's us.
That's
We're
us.
just like, oh, it's a geriatrician.
We're a little more because we always dig deeper
We
Mhm.
dig
to
pretty
find the
deep.
nuggets.
That's right. And
That's
we could be everywhere too, you know, like you mentioned the house calls, and you know we really get established. We're getting to know the patient better, and our ultimate goal is to keep them as well taken care of, as functional as long as possible. And I was just in a PACE program where older frail adults, half of them have dementia. They get to be cared at home, but they go to an adult daycare center where they get to have a lot of fun activities. Their family get to have a rest, and the geriatrician get to see them there, and the geriatrician in the PACE program get to keep them in the community as independently as much possible. So we're everywhere.
Yeah, and there was actually some research that showed if you have a geriatrician, it keeps you out of the hospital and it helps save you money. So I think it said like $800 a year by not going to the ER, because ERs are so expensive.
right. And if a geriatrician sees you before you have some type of hip surgery because of a hip fracture, then the likelihood of developing delirium goes down by like 30%.
Mhm.
I mean, that's pretty cool. So,
Very significant.
right. So who wrote that blog on delirium?
I think you did.
Did I write that? For
Yes,
some reason,
you
I thought
did.
you wrote that.
I mean, I do love it. It's one of my like true loves in the hospital, because hypoactive or hyperactive, I love them both.
I do too. It's a favorite diagnosis.
Yes.
Yes.
Mhm.
All right. Who's up? Myth number 8.
Myth number 8, dementia is a normal part of aging, which is incorrect. The old way of thinking is that older patients just got senile as they age. This was before dementia became a diagnosis. There's, slowing of memory as we age in almost everybody, but dementia is not, or is a faster progress than just the normal memory loss progress. So dementia is not normal.
And there is different pathology, right?
Mhm.
When you look at brain scans of different types of dementia. So it is not a normal part of aging. If you notice mom or dad or grandma or grandpa forgetting, maybe I forget what I ate for breakfast, I'm repeating myself, maybe the same thing multiple times, calling, asking the same questions, that is not normal.
Or getting lost in
Getting-
usual spots.
Exactly, getting lost while driving, or sometimes forgetting to turn on the car, like something they had done
Mhm.
so many times.
Forgetting to take care of the car. My husband got hit by a car that was on fire, backing into his car at a traffic light. He had to pull that old gentleman out away from his car, because that moment that older gentleman really truly had no idea what was going on. He kept saying, "Oh, I didn't do it," but he was definitely in distraught, and very high chance he has some kind of cognitive deficit, and he could have been in serious danger if
It's like a rolling fireball.
it was rolling,
Well,
car
for a moment,
that was on fire.
when Dr. Wang said my husband, I was like, are you going to say Chris has dementia?
No, that's something he had flying at him.
I mean, I did cognitively test my husband
Did you?
because he has some difficulties with recall, and apparently I do too now, because he told me he had to get dental work on Monday.
That's a perfect example. Everybody has bad memory moments. Everybody forgets stuff. When it becomes a danger, when it becomes something more than will usually, and it will impair your day-to-day activity, then it's not normal. So
Right.
Definitely get it checked out and get it managed, treated, however, so that you wouldn't get yourself in spots of danger, or your loved ones would be protected.
So you're not in a rolling fireball.
Oh, yeah.
Right. But just on a serious note, though, you can have younger patients develop memory problems
Mhm.
where you can have an actual memory disorder.
Yeah.
And so for us, if you have someone in their 40s or 50s, there's likely a genetic component, but developing serious memory issues, or even if, I laughed at that, but even if like I thought, oh my gosh, something's not right, I detected something is not right, I think you can still see geriatrics, but definitely absolutely need to see a neurologist, because that is not normal either.
Mhm.
And the sooner that you intervene and see somebody, or your loved one sees someone, the longer you can preserve your memory, the more likely you can find out what the root of the problem is
Mhm.
and address it, which is really important. Okay, guys.
Absolutely.
So myth number 9.
So myth number 9, I don't need to see a geriatrician for urinary incontinence. Incorrect. Any female with urinary incontinence should see a geriatrician. This is because urinary incontinence can be the first sign of frailty. And I talked about this in my blog and my podcast a few weeks ago. And, we worry about incontinence because if you're rushing to get to the bathroom, again, you might fall and hurt a hip, or you might trip and hit your head. So anytime you have urinary incontinence, it's good to just get it checked out. It's nothing embarrassing. It happens to a lot of people, but it's just good to get it checked out. And early intervention for this urinary incontinence might mean a better quality of life and decrease the risk of developing frailty syndrome that's on that continuum that you can see the picture on our blog to maintain your independence.
Right. I just thought of another myth. Okay, myth number 9.5.
9.5.
Right. Everyone gets a urinary tract infection when they're older. And that's not true either, right? Because about
not at all.
30% of women can have colonization. So they can have bacteria that may appear to be a urinary tract infection, and it may not be. And every time we treat these urinary tract infections, or not true urinary tract infections, then we build more resistant bacteria, which will need actual antibiotics, and these antibiotics, will run out of an antibiotic and it can be harmful to a patient. So important to see a geriatrician, important to address that with primary care, and important to possibly even see a urologist when you're kind of in this cycle.
And something important also is if your family has a Foley catheter, and they go to the doctor and they're like, oh, they've been confused, let's check their urine. If they've had a Foley for more than 3 days, it's gonna be contaminated. It could have 17,000 bacteria in there, but that doesn't mean they have a urinary tract infection. It's just the bacteria live in there because it's pee and it's warm and they're happy.
Yes.
So especially if your patient has a catheter, it's even more difficult to get a good, clean urine sample, as clean as urine can get. Apparently it is sterile.
It is. Yeah. Oh, unless, and also if you have diabetes and you're leaking a little bit of sugar, right, then you're going to have even happier bacteria trying to live there. Right. So, okay. Myth number 10.
All right. Myth number 10. My parents or spouse only sleep about 6 hours a night. Is that normal? Well, this surprisingly is. As we age, we do need less sleep to keep us functioning. On average, old person only needs 6 hours of sleep in 24 hours. So your family member is napping most of the day, they will likely be up all night. So it's very important to keep them awake as much as possible so they could reorient to that normal day and night cycle so that they don't end up staying up all night.
One other thing we see, and then we talked about this in the delirium podcast, is when loved ones come to the hospital and their family member is sleeping and they're like, let them rest. They didn't sleep all night. And what do?
Wake them up.
We wake them up, pull up the blinds, and drive everyone crazy.
Turn on the lights.
But we stop it, right? We sort of need to stop that cycle. It's kind of like reinforcing the bad habit. And so making sure that your loved one is active, up, awake during the day, not just in the hospital, but at home too. Think, your loved one with dementia, they shouldn't just be sitting around all day. They need to be active and doing things. And so once you do keep them active, and once they are doing things and engaged as much as they can be, depending on the stage of dementia, then they're more likely to get a better night's sleep. And I don't remember if we talked about this too in another podcast, but we talked about melatonin medication. It is used for sleep. So really, melatonin should be taken about 4 hours before sleep, no more than 1 to 3 milligrams. And so if you want to help your loved one get to sleep, or if you're having some trouble sleeping, you could try some of that in the evening, about 4 hours before going to sleep. Again, if you go to bed at 9 o'clock, you may be up at 3 a.m. and that could be a full night's sleep because your sleep cycles change as you age.
Yeah. And common misconception is that I take melatonin right before I go to bed, but this is not how it's supposed to be used, right? It's not a sedative. It doesn't make you sleepy. It's part of the natural hormone your brain produces. So if you take it the normal circadian rhythm time, then that will work better.
And don't take Benadryl. I'm a Benadrylian. I used to take Benadryl all the time to make me sleep, but it's been linked with cognitive impairment. And I don't know if you saw this, but on the Physician Mom group on Facebook, there's all these pearls of your specialty. And one of your previous fellows, Dr. Hardin, said that someone was taking 32 milligrams of melatonin. Just do like the 3 milligrams.
Oi!
32 is a lot.
They must have had some wild dreams. The higher the dose, the weirder the dream.
With some Benadryl and some Tylenol PM.
Oh, wow.
Too
Yeah.
much.
So, well, I think this was fun, right?
This was
Talking about the
fun.
myths.
That's
And
how cool we are.
that's so cool.
Geriatricians have fun.
So, Dr. Cannon, I know you were kicked out of your choir. Can you just sing us out of here?
Welcome to Jerry Academy.
Thank you, guys. Bye.
Bye.
Hello, welcome to the Geri Academy podcast with your host, geriatrician Dr. Golnu Sharafsaleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media.